In oncology, time to treatment initiation is a matter of life and death. Yet, at community cancer centers, patients wait weeks for just to their case to be reviewed at a multidisciplinary tumor board. Why? Because a nurse navigator or an oncology fellow must spend 45 to 90 minutes per patient digging through the EHR, manually synthesizing dense, unstructured pathology and radiology reports into a cohesive presentation. It is unbelievable soul-crushing data entry that caps a hospital's throughput. Current EHRs like Epic cannot cross-reference unstructured biomarker data against imaging narratives to auto-calculate staging. That's why MDT Assemble was ideated. We aren't replacing the tumor board. We are automating the 90 minutes of prep work so human doc can sit down and instantly make decisions. We achieved this using prompt opinion to compose specialized A2A agents into a single workspace. In healthcare AI, hallucinations are an invitation to malpractice lawsuit. That is why we built a hybrid neurosymbolic architecture. We use generative AI purely as an extraction engine via A2A, but for clinical safety, the AI is explicitly forbidden for calculating the cancer stage. It must pass the extracted DNM values into our fast MCP server, which uses deterministic hard-coded Python logic to calculate the AJCC stage. Finally, we operate on a zero-trust model, requesting only specific smart on fire scopes via the sharp context. Let's see it live. We have a 40-year-old male, Glenn Sharlock. He recently had a lung biopsy and a chest CT. As the lead oncologist, I just need to prep his case. While it orchestrates, look under the hood. The coordinator doesn't do this alone. It delegates. It hits our fast MCP server to grab Glenn's demographics. Then via A2A, it consults our specialized pathology agent to extract the exact histology and NGS biomarkers from the unstructured fire context. Notice the strict JSON schema enforcing the response. Then it hits the radiology agent for tumor dimensions. Let's look at the correctness of this output. First, look at sections 2 and 3. We built 100% cryptographic provenance. Every finding includes the exact fire document ID it was extracted from. If an oncologist questions the tumor size, they have the exact citation to audit the AI's work. Second, look at section 4. The LLMs didn't guess the stage. Our Python server deterministically evaluated T2B and to M0 to guarantee the mathematically safe stage 3A classification. But finally, look at section 5. The pathology agent found that Glenn has high PD-L1 expression of 80%, but is also EGFR positive. This is a complex clinical nuance because we built a strict RAG engine. The AI didn't hallucinate the treatment plan. Instead, it queried our deterministic fast MCP guideline tool, which retrieved the exact pre-approved NCI pathway from our database. It successfully surfaced the hard-coded clinical hierarchy. Oncogenic driver mutations override PD-L1 by retrieving the exact right guideline for this specific biomarker profile. The AI isn't making the final decision. It is organizing a highly complex, competing biomarker matrix. Finally, a read-only AI is just a toy. Our coordinator takes this markdown, encodes it in base 64, and securely posts it back to the FHIR database as a preliminary document reference. The physicians review the action items, sign the attestation block during the board meeting, and the loop is closed. We just turned 90 minutes of administrative burden into a maybe 10 to 20 minute mathematically safe interoperable workflow.